Good morning, everyone, and welcome to the third annual Neuro-Oncology Symposium. The symposium has been organized by the Aga Khan University, Pakistan Society of Neuro-Oncology, PASNO, Pakistan Academy of Neurological Surgery, PANS, in collaboration with the Pakistan Society of Pediatric Oncology, Brain Tumor Foundation of Pakistan, the Neuroscience, Surgery, and the Student Oncology interest groups at the Aga Khan University. I am Fatma Gohar, a medical student at the Aga Khan University, a member of the Student Organizing Committee, and the president of the Neuroscience Interest Group. For the past 2 years, Annual Neuro-Oncology Symposium has made a mark globally in being the perfect amalgamation of understanding and questioning the present to drive for excellence for today and for the future. With our esteemed speakers and guests, dedicated faculty, enthusiastic students, and of course, our attendees. The third annual Neuro-Oncology Symposium will make its mark again as a nucleus of knowledge in neuro-oncology. I would commence the symposium with our first session. It is a significant honor to be opening the Mark Rosenblum Keynote lectures to officially welcome you all and introduce the session and the symposium. I invite the president of the symposium committee, and Pasno, Professor of Neurosurgery at the Aga Khan University and holder of the Presidential Award, Sitara Imtiaz, Professor Syed Athar Naam.
Thank you very much, Fatma. And this 3 annos was, we wanted it to be all physical, but then we were not sure about it when we started to plan it a few months ago. So we made it hybrid. Next year, which will be 4 annos, we will make it all physical. So this year's annual Neuro-Oncology Symposium 3 annos is exceptional as we introduce the Mark Rosenblum Keynote lectures. Dr. Rosenblum is currently Chairman Emeritus of Department of Neurosurgery in the Henry Ford Health System. Professor Rosenblum's professional career embodies the constant struggle to improve brain tumor patient care and capacity building. We at the Pakistan Society of Neuro-Oncology strongly feel connected to his lifelong determination. The vision of PASNO is to nurture and produce leaders in global neuro-oncology. And the mission of PASNO is to improve the care and treatment of brain tumor patients in Pakistan and the region. We achieve this by enhancing public awareness of neuro-oncology, organizing academic activities for professionals, facilitating multidisciplinary collaboration to stimulate locally relevant research, and networking with neuro-oncologists around the world. Dr. Rosenblum obtained his bachelor's in Rensselaer Polytechnic Institute, his MD at New York Medical College. After his internship from University of Michigan, he finished his surgical residency in UCLA and then his neurosurgical residency in UCSF. At UCSF, he helped develop its world-leading brain tumor research center, and he became professor of neurosurgery. He was continuously funded by the NCI and American Cancer Society for early research on cancer stem cells. In 1984, he founded, and for 7 years, he chaired the section on tumors of the American Association of Neurological Surgeons and Congress of Neurological Surgeons. This was one thing that created the most impact internationally of his overall activities in neuro-oncology. During his tenure with HFHS, Henry Ford Health System, Dr. Rosenblum developed nationally recognized research and helped provide the system national recognition for clinical excellence. He also founded the Hermelin Brain Tumor Center and the Henry Ford Health System Neurosciences Institute. And he was involved in a lot of other clinical activities, setting up different centers. I was a witness, first-hand witness to all those activities, which inspired a lot of trainees when he was a chair at the Henry Ford Health System. He was one of the 4 leaders who developed a new novel patient-focused hospital, which was Henry Ford West Bloomfield Hospital. He served as vice president of the clinical programs and director of its Center for Health Services Transformation. While at UCSF, he is also credited for doing a lot of other academic activities beyond neuro-oncology. Dr. Rosenblum has received many awards for research and clinical work, including the first Charles B. Wilson Award from the AANS and CNS for lifelong contributions to neuro-oncology and from the American Cancer Society, his own medical school, as well as Henry Ford System, and he was named in America's Best Doctors and many other awards. He was an honored guest in the CNS annual meeting last year. He has published 7 books, 240 articles and chapters, trained 63 neurosurgeons, and raised $45 million in philanthropy for neuroscience. Dr. Rosenblum is an enterprising, he builds connections, he networks with a focus. The goal that he has in his mind stays focused in his mind, and he has shown results at how you can do it in your lifetime, make an impact that goes beyond your local area and can have an international impact. In the words of Dr. Rosenblum, we haven't done much over the last 50 years to treat GBMs. However, with the disruptive innovation of molecular diagnostics and therapeutics and an increasing role of neurosurgery, both developing proper tumor banks and multidisciplinary tumor programs in conjunction with other specialties in neuro-oncology, the future is even brighter. I'm honored to have the keynote lecture series named after me. With such collaborative efforts, we will be more likely to control the devastating tumor we all are focusing on in the laboratory and clinic. So it's an honor to name this keynote lecture series after Dr. Rosenblum. And we would like to hear Dr. Rosenblum say a few words in this regard. Thank you.
Thank you very much, Dr. Inam. As you mentioned, I've been at this for over 50 years, and as anyone knows who's been dealing with glioblastomas as measured in overall survival, there's really been very little measurable advances. Of course, surgery is much safer now, and by removing the majority of tumors, tumor cells, as long as you don't hurt the patient, there's been several months at least of increased survival for glioblastomas. Postoperative treatments, however, unfortunately have been less than optimal. Most importantly today, and I think in the near future, has been the development of surgical tumor tissue banks that's enabled molecular analysis and advances. And as Dr. Inam had mentioned, the future should be brighter, particularly with the advent of precision medicine and anyone dealing with other oncologic specialties, especially lung cancer and several others, with particular mutations. There have been agents that have been developed that have been remarkably, have given remarkable results in patients, including those that have metastasized to the brain. A number of us started the tumor section 38 years ago, almost 38 years ago today. We did that in order to enhance clinical care and research, in order to combine experts in neurosurgery with other neuro-oncology specialists, in order to develop leaders in the field, and there have been many leaders that have had part of their start and advancement through initially the section, and to increase advocacy within neurosurgery, oncology, institutions, governmental organizations, and the public. And also, finally, to expand the effort internationally through neurosurgery leaders globally. The Pakistan Society of Neuro-Oncology, under Dr. Inam's outstanding leadership, and through their annual Neuro-Oncology Symposium, exemplified the absolute best of such efforts. For example, in 2021, the second annual symposium had more than 2,000 participants from more than 140 centers and 44 countries. That's really quite remarkable for something that's just recently started. I'm honored to have the annual symposium keynote lectures carry my name. And it's, as Dr. Yanam had mentioned, with such collaborative efforts, we are more likely to enhance evidence-based clinical care and research, of course, modified based upon local capabilities, and to elevate the care of patients around the world. As he had mentioned, and I firmly believe, and I'm sure Dr. Carter and Dr. Defoe believe as well, that the future is in our hands, and the future is looking even brighter today toward control, at least control, if not cure, of these devastating tumors. And I thank you very much and looking forward to hearing these next speakers and really greatly appreciate the honor. Thank you.
Thank you, Dr. Rosenblum. So we are honored that the first keynote lecture series is, we have Professor Bob Carter from Mass General Hospital of Harvard and Professor Hugues Defoe from Montpellier University Medical Center, France. They accepted our invitation to deliver the Mark Rosenblum keynote lecture this year. Both are at the pinnacle of their area of interest, and we could not have asked for more. Professor Bob Carter is an MD, PhD. He's a board-certified neurosurgeon specializing in complex intracranial surgery, including brain, pituitary, and skull-based tumors and brain aneurysms. Dr. Carter is the chair of the Department of Neurosurgery at Mass General Hospital at Harvard Medical School, and he's the William and Elizabeth Sweet Professor of Neurosurgery at the same institution. Prior to joining Mass General, Dr. Carter served as professor and chair of neurosurgery at the UC San Diego School of Medicine. He has been elected to America's top doctors. Dr. Carter is a fellow of the American Association of Neurological Surgeons and a member of numerous medical organizations, including the Congress of Neurological Surgeons and American Academy of Neurological Surgery. He serves on the program committee for the American Stroke Association's International Stroke Conference and has served on the executive boards of the Joint Cerebrovascular Section and the New England Neurosurgical Society. Dr. Carter is extensively published and he lectures internationally on neurosurgery topics. He served as the chair of editorial board of Journal of Neurosurgery and editorial advisory board member of neurosurgery. He co-leads as the nation's leading brain tumors program, which is the Mass General Hospital's brain tumor program. It brings together over 100 faculty members, and they are focused on brain tumor clinical care, research, and education. Now, specifically related to neuro-oncology, Dr. Carter's scientific work has included the development of the first reported EGFR8 directed CAR T cell therapy and first characterizations of exosomes in glioblastoma. He is a principal investigator in the NCI's liquid biopsy consortium. He leads a team of clinician scientists who have developed the role of big data in characterizing outcomes in oncological and vascular neurosurgery. As a neurosurgical oncologist, he takes a leadership role in shepherding research in the SMICH's Brain Tumor Research Center. Dr. Carter has organized consortia and served as PI of multi-center studies in the analysis of extracellular RNA as a biomarker, including serving as a PI in NIH's Extracellular RNA Communication Consortium and NIH's Liquid Biopsy Consortium, as mentioned. The most interesting thing about Dr. Carter is that despite his predominant role in neuro-oncology, and despite being such a busy neurosurgeon, leading such a busy program, he has time for everyone that tries to contact him. I don't know how he does that, but whenever a student from over here emails him, he replies back to that student. He is truly a global neurosurgeon, or I should say a global neuro-oncologist, and he makes sure that his impact goes beyond the boundaries, the geographic boundaries. So in that sense, just like I mentioned, Dr. Rosenblum, in whose name this keynote lecture series is inaugurated, Dr. Bob Carter has the same role of involving everybody internationally. And it could not have been a better choice to have the first keynote lecture series done by anyone else but Dr. Bob Carter. Interestingly, Dr. Bob Carter was also the honored guest along with Dr. Rosenblum last year in the CNS Awards. So the first talk of this keynote lecture series is very appropriate, and he will talk about the advances in cell and gene therapy for brain tumors. Thank you, Dr. Bob Carter, for being here late at night. It's almost midnight over there. Thank you.
Thank you, Professor Anam. And let's see, I'll go ahead and if we switch the screen sharing, I can share my screen. There we go. And I'll bring up the slides here. And okay, so thank you again. So this is a great honor for me to be not only associated with Dr. Rosenblum's name. I've come to know Dr. Rosenblum in recent years in the way that many of his trainees and mentees have, as a very special individual. So Professor Anam and the entire society, I want to thank you for this special recognition, which means a lot to me personally. And I hope I can do some justice to Dr. Rosenblum's mentorship and guidance in the field of neuro-oncology in these many years. I'm also really delighted to have the chance to connect again on multiple levels with Professor Anam, who visited us at Mass General this last year and really made quite an impression on all of us with the wonderful things that PASNO is doing and highlighting the outstanding efforts to bring really people together for conversations on how we advance our field in so many different dimensions. So thank you, Professor, also for this opportunity to be with the entire group today. I want to talk a little bit about gene and cell therapy and really just kind of frame it a little bit in the context of the larger challenges that Dr. Rosenblum highlighted related to where we are in the treatment of GBM and why we really need to think about new therapies considering the challenge. Now, I was actually born in this part of the United States, just at the foothills of this mountain. So I often think about summits and trying to climb these challenging summits with the work that we do. Many of our scientific pursuits, our clinical pursuits, can seem like overwhelming challenges at times. But as we begin to break down the problems, we start to think about new solutions. And certainly GBM is a worthy summit, a worthy challenge for all of us. If we look at just the actual data of the last many years, and this is survival data from the United States SEER database, the largest cancer registry essentially in the United States. And if we look at the multi-year survival, the 5-year survival of gross total resection of GBM, you can see it's a very small percentage of patients that make it out 5 years. And similarly for anaplastic astrocytoma, also a very devastating decrement in the overall survival as the years go by. Now, this is, of course, just considering all patients with all different histologies and all different molecular backgrounds. But we know that if we even go further and begin to divide this up, if we look at age, for example, there is a strong age effect. Younger patients do better, likely related to many of the molecular alterations that are reflected in younger patients. But still, it's a really devastating illness and one that we don't have wonderful cures for. We have some treatments, but they're very modest in their overall effect. And I don't think this is anything that any of us want to see stay in its current state. So this brings us to additional questions. What have we started to learn that might improve this situation? Of course, one of the things is the understanding, particularly in the last decade and the last, say, 15 years or so, of the molecular alterations that really drive these tumors in the central nervous system. And the 2016 modified WHO classifications, which now incorporate molecular diagnostics, have been, I think, critical in terms of setting the stage for development of the next generation of therapeutics. We know that this is important as we look, for example, we've always known that histological correlates of survival were there. a GBM patient fares far worse than a patient with an oligodendroglioma. But as we begin to break that down into specific mutations, you can take two mutations alone, the TERT mutation and the IDH mutation, and simply assaying those two mutations in the tumor will also reveal dramatic survival differences in the population. A patient who's doubly mutated in TERT and IDH likely again has an oligodendroglioma, whereas a patient who has a TERT mutation alone may be reflective of simply a GBM with a very poor survival. Now, as we see these molecular alterations, of course, we know that there are far more than just two, and we can begin making not only strategic determinations about prognosis, but also beginning to imagine and conceptualize new therapies based on these alterations. And of course, again, this detailed schematic that was provided me by Dr. Lewis, who's our chair of pathology and was instrumental in writing these WHO new classifications. Really, the reports that we're getting now go far beyond histology to incorporate genetic and molecular markers. And again, the plethora of these markers and their correlates with age and different locations of tumors, I think, again, set the stage for the next generation of therapeutics. And these are now becoming much more familiar to all of us. Can we use this molecular information for early diagnosis and perhaps to help direct and monitor biological therapies? I think the question to that is yes. Certainly, we are on a phase of planning. On the point of monitoring, one of the strong areas that's evolving that I won't have time to dive into deeply today is the issue of liquid biopsy. And how do we begin to assess changes in the patient's clinical status through a blood test or a cerebrospinal fluid test. And we know now that we can detect in the plasma and in the cerebrospinal fluid multiple fractions, the tumor cell-free DNA fraction, the exosome fraction or extracellular RNA fraction, and the circulating tumor cell fraction. These are all becoming accessible to us. And as we learn more about the primary tumor and the primary tumor mutations, we can also understand more about these liquid biopsy opportunities and fractions. Now, if we look further into this, there's one thing I want to highlight, and that is the following. The scientific process is truly an iterative one. It's one where we come up with an idea, we begin to put out a prototype, that might be a phase 1 study. We begin to conceptualize this idea, we put it into practice, and then we find out actually there are things that we didn't anticipate. There were unknown unknowns that we need to actually better study, better try to approach with our strategy. And it's very rare that on the first iteration, we're going to get it right. I'll give you an example of this. Some years ago, we published a paper. This was in 2008, so 14 years ago. And in this paper, a team, Xander Brakefield, Johan Skog, and later followed up with work by Leonora Belay, who are pictured here. We discovered that on the surface of GBM, there were small vesicles. These were released into the bloodstream. In this paper, glioblastoma microvesicles were shown to transport RNA and proteins. So this was a new concept, and this paper has been cited many times, and it revealed the potential of a new idea, that GBMs could secrete these vesicles, and that perhaps in the blood we could assay the genetic material, and from that genetic material make inferences about the tumor, early diagnosis, or even response to treatment. But there were challenges 14 years ago. One was that the signal had incredibly low abundance, and that the body fluids that we're assaying were very heterogeneous. That is to say, there could be extracellular vesicles not only from the tumor in the plasma, but also from other organ systems. And the idea was that maybe in certain scenarios, this could be useful, a difficult to biopsy lesion, characterized now by a blood test instead of perhaps an invasive test, or being able to sort out things like radiation necrosis or pseudoprogression. And then, of course, therapeutic monitoring, particularly in the context of new therapies like immunotherapy. Well, 14 years have passed by. What have we been working on? We've been working on trying to make assays related to liquid biopsy better. And sometimes it takes really just the persistence and the new energy of different individuals. And I want to highlight Maheen Batul, who came to us from AKU a couple of years ago to research in our laboratories. And Maheen just published a paper in Clinical Cancer Research, now showing that with about 73% sensitivity and 98% specificity, we can detect in plasma by digital droplet PCR these EGFRB3 mutations that occur in brain tumors with, again, this high sensitivity from extracellular vesicular RNA. And just coming full circle with PASNO and the mentorship of Dr. Anam, we see that a contributor from across the world now has a paper that really fleshes out and develops this idea that was conceived of over a decade ago, and is bringing it forward closer and closer to the clinic with each improvement and iteration, as I was previously describing. So I want to talk about 2 examples of additional iteration in gene and cell therapy. I'll go through these somewhat quickly because we're always going to be a little short on time, but there's been a large community of individuals who've been interested in this, and there's absolutely no way I can give full credit to everyone that's been involved with this, but this is an area of active interest for many. I want to really highlight the oncolytic virologists, individuals who are interested in turning viruses into weapons against brain tumors. Particularly, this group has been focused on central nervous system disorders, and these are some of the pioneers in this domain. And I'll highlight some of the work that's occurred by one of my mentors, Robert Martuza, up here in the upper left-hand corner, the prior chair of neurosurgery here at Mass General, who really was a pioneer in developing this concept that's now come to fruition. The concept is relatively simple. Infect a brain tumor cell with a virus that has been engineered by us, and have that virus kill the tumor cell and leave all the other surrounding cells intact and functioning normally. Now that's the concept, but of course there are many technical challenges to making that concept come to life. This is the visualization of that. We have to deal with the fact that there are normal brain neurons admixed with tumor cells, viruses that we're hoping to have attached to these tumor cells, and trying to achieve this specificity, throwing these so-called therapeutic darts and not causing damage, but then again, being able to do what surgery can't do, which is to target tumor in diverse regions of the brain away from a primary resection site. So that's the engineering challenge, target specificity. And there are many mechanisms that have been employed and are continuing to be employed to develop that specificity. Cell surface targeting, gene expression-based targeting, extracellular mechanisms, for example, immunomodulatory targeting. And the idea of these different approaches that have been employed is, again, to achieve that specificity that I mentioned. Now, the HSV, or the herpes simplex virus genome, actually offers some unique opportunities for gene engineering. For example, this virus is very dependent on an enzyme that it contains within its own genome, ribonucleotide reductase. This allows the virus to make sufficient DNA for viral propagation. Bob Martuza, back in 1991, had the idea, well, what if we take the virus and begin to alter it in such a way that it only receives that additional enzymatic support from the tumor cells, but not normal cells? And we know that GBM cells are highly upregulated in DNA production and hence highly upregulated in RNR, or ribonucleotide reductase, and that the normal non-dividing regular neurons within the brain, in fact, have very low levels of expression of this enzyme. So this was a difference that could be exploited by a gene engineering approach. And the idea, again, was to build this virus, and a sequence of viruses were built that took advantage of different modalities to take that virus and have it specifically target tumor cells with preservation of normal brain neurons. Well, many other groups began to fold into this, and a series of investigations began to occur over really 2 to 3 decades now. with that first description of a genetically modified virus back in 1991. Within 10 years, the first phase 1 trials of these modified viruses in the G207 virus. Later, additional modifications occurring in the mid-2000s, the RQ-Nestin virus being developed, and then additional viruses now that contain immune modulatory molecules. And then in the last couple of years, some interesting and important breakthroughs. The first approval in Japan of the G47 Delta virus for primary GBM treatment. And then again, ongoing development of new modified strategies coupled with our molecular knowledge and understanding. And then in recent years, better understanding of the tumor microenvironment itself. This was a New England Journal publication just in the last couple of years on the use of G207, one of these viruses for pediatric high-grade glioma, and the concept of taking that microenvironment, which is immunologically cold, and turning it into an immunologically active microenvironment. Now, as Mark has noted, none of these strategies as yet has made a substantial dent in the overall survival of GBM. But we've set the stage and we've developed the foundation of work to go to that next level in the iterative process. One of the strategies that Bob Martuzza, who's still very active in this domain of research, is employing today is to arm the viruses with pro-inflammatory molecules to capture and recruit additional immune infiltrate into the region of tumor and have additional expansive effect. And in fact, this has been a conceptual change. When the viruses first were developed, it was thought that their primary activity would be through propagated lysis of the tumor cells. But really, we understand now that it's a combination of lysis and immune activation. So the modifications that we do to the viruses today, the goal is to generate that immune modification. Now, the FDA approved the first in melanoma, the first oncolytic virus in 2015, just 7 years ago. And we are now getting that other approval in Japan for the first brain tumor specific virus. So I think we're on the cusp of that next stage of activity. And I call it a stage because each scientific advance from generation to generation really is a stage and a phase to try to get up to the top of that summit of making a dent in GBM survival. Now, if you look at, this was just pre-pandemic, this publication came out, or right during the pandemic. There are approximately about 30 trials right now of oncolytic viral vectors in brain tumors. Overall, we're seeing kind of in this first phase of viruses, these are generally lytic viruses without additional modifications. We're sort of seeing some of the types of results that you see here, and then we'll be getting larger results out in the next couple of years from some of the larger studies. I want to point out again this iteration effect, because again, it comes back as a theme in biological therapies. If you look at this study, which is the largest oncolytic viral study to date, this was the 403 patients that were randomized in the Tokagen trial. And this was a replication competent retrovirus with a combination 5-FU treatment to activate the virus versus standard of care. What you see here is two absolutely overlapping curves. No effect, despite promising preclinical and phase 1 and phase 2 types of comparative studies. So this was, again, a first generation virus focused on lysis without much in the way of modification in terms of immune modification. But it points out that we haven't solved this problem yet. And this is a problem that is going to require additional iteration in engineering. Really the merging of two concepts, the viral lysis concept and the immunotherapy concept. And this is in Cancer Cell a few years ago, Bob Martuzza and Sam Ravkin published this paper where they took their oncolytic virus, they armed it with the secretion of IL-12, and then they added in immune checkpoint inhibitors. So now they're bringing really three concepts together, the pro-inflammatory secretion, the lysis, the checkpoint inhibitors, all to achieve a better overall outcome. I think the key here is believing in that vision and keeping pushing forward and improving these ideas. but that captures a bit of the state of the oncolytic virus story. Now, I have time to briefly touch on one other story, which is out of what I call the gene designers. And this is really the idea of taking cells and modifying the cells to our own purpose. If you'll recall your immunology from medical school, we know that the normal T cell requires activation through peptide presentation on MHC1 complexes so that the T cell receptor alpha and beta chains can engage that antigen and redirect. And we know that GBM, this process is dramatically interfered with from a number of different standpoints, not the least of which is downregulation of MHC1, which occurs substantially in GBM. GBMs have great immune escape mechanisms. The CAR-T genetic engineering approach takes a different strategy. And here the strategy is to actually directly engage the intact antigen through a genetically engineered CAR-T receptor. And I'll show you a little bit about those receptors here shortly. This, of course, has been a breakthrough in the lymphopoietic cancers, and we've all seen that in our own hospitals in recent years. Number of years ago, many years ago, we began to develop these types of CAR-T receptors, including those which target a prominent antigen in GBM, EGFRvIII. And now we've progressed in that iterative process through multiple generations of this approach, from a first generation CAR-T receptor with a single targeting moiety on the surface and a single signaling domain, to a second generation and now third generation receptor with multiple signaling domains. And in fact, this video sort of shows how these receptors work. On the right side of the screen, you see plated glioblastoma cells that are being scanned, targeted, and lysed by CAR-T modified T cells, genetically engineered in the laboratory to have a specific specificity against those GBM cells that express EGFRvIII. And as this time goes by in this time lapse, you see that all the cells are lysed and wiped out. But over on the left, you also see the Achilles heel of this approach. These cells are also glioblastoma cells, but they do not have the EGFRvIII antigen upon them. And these cells on the left are being scanned, but they're not being lysed. So we have a sense here of what might happen in a clinical trial just from this early work. And in fact, what we saw when the Don O'Rourke and the great team at Penn put this into a clinical trial with systemic infusion of EGFRvIII CAR-T, they found that, in fact, there was an initial response, there was an initial lysis effect, and you could see that on imaging. But the tumors all came back, and they came back because the tumors did exactly what we thought they would. They lysed all of the EGFRvIII positive cells, but the remaining negative cells, such as the EGFR wild type, those cells lived on and continued to lead the recurrence of the tumor. So the antigen-directed therapy worked in part, but then the recurrence occurred because of the failure of the therapy. And so that's a challenge that has faced the field in a heterogeneous tumor like GBM. And this tumor antigen loss is a significant Achilles heel of any immunotherapy and any directed therapy. But once again, the iterative process is critical. So one of my colleagues, Dr. Brian Choi, shown here on the left, and with mentors Will Curry and Marcella Maus, started to ask some questions. Can we make this better? One question was, could we design a CAR-T that instead of targeting one antigen, would now target multiple antigens? And so what Brian and his team showed that is indeed it's possible to make a tandem CAR, one that secretes or has a bispecific binding moiety. And these constructs look a little bit like this. The vectors themselves, instead of just having one or a single antigen, now combine antigen recognition domains from multiple, in this case, IL-13 and EGFRvIII. And Brian's team went on to show, has shown in the recent years that actually these tandem CARs activate and they proliferate in response to single antigen stimulation, but they also are effective against heterogeneous tumors in patient-derived xenografts. So it's, again, a bispecific CAR now available. He also asked the question, could we design a CAR T cell that could co-opt or bypass these infiltrating suppressive cells that are in the microenvironment. And the answer to that was to create something called the bispecific CAR with a secreted BiTE or bispecific T-cell engager. And these CARs are a little bit different. The idea here in the genetic engineering approach is to have that CAR specificity for the initial attack, but that the T cell itself is now engineered to secrete an additional immune modifier. And these are the BiTEs, or the bispecific T cell engagers. These are molecules that on one end have a single chain antibody to a target antigen, and on the other end, they have actually a single chain antibody to the T cell receptor, bringing T cells and tumor cells that express the antigen into close proximity, and this proximity allowing for lysis. So now you have a set of cells that are supercharged. These are CAR T cells that have a specific binding moiety that takes them and helps them bind to tumors. Or these are engagers that bring T cells again into the tumor and cause this type of engagement with the molecule to create the lysis effect in a broad field. And Brian has shown that this develops an appropriate toxicity through granzyme-dependent mechanisms, and that these can be bicistranically expressed in addition to the CAR T itself at high levels of expression. And that both bystander cells and the targeted cells can be engaged by these BiTEs appropriately. And in fact, that this CAR BiTE therapy is efficacious against tumor antigen loss, because now you're bringing a T cell non-specifically up against the antigen without requiring the CAR therapeutic itself. And that these cells also are less susceptible to exhaustion because of their modifications to the local suppressive cells in terms of activating those cells. Now, one of the things that Brian has also asked is, can we modify these CAR Ts to overcome local tumor-associated expression of checkpoint molecules? And this approach involves taking advantage of knowing now the molecular underpinnings of how immune suppression occurs. We understand that the negative aspects of checkpoint inhibition alter the microenvironment in such a way that GBM can escape these types of targeted therapeutics or immune therapeutics. And that we know that simple CAR T cell therapy naturally does lead to altered local PD-L1 expression, again, further exacerbating this problem. So here the idea is to delete PD-1 in the CAR T cell itself so that it's no longer susceptible to the expression of of PD-L1, and therefore now permits these supercells to be resistant to the local immune suppressive microenvironment. This was published just a couple of years ago, and the lab has gone on to show that these CAR T cells that are modified have better persistence. They're less susceptible to the microenvironment immune suppression. And this can be done with CRISPR gene editing, which also allows us to envision modifications further that would permit an allogeneic type of approach. So we might not have to make a patient-specific product, but rather an allogeneic product that could be used in many patients. So this is the idea. It's a designer T cell. It's a super T cell. It has CARs on its surface, which take the cell towards the antigens in the tumor. This designer T cell secretes BiTEs, which provide additional upregulation of typically suppressive immune cells to now also target the antigens of interest. And then also the elimination of the PD-1 Achilles heel of these cells through genetic CRISPR modification. So where do we go for this? Well, this is, of course, there's all the manufacturing and the GMP manufacturing required and the associated regulatory approvals. But we're planning to launch in this next few months a trial called Incipient, and this is going to be an intraventricular CAR T BiTE cell therapy for patients with GBM. It's a single intraventricular injection of these CAR T BiTE cells, and the eligibility will be patients who are EGFRV3 positive and then MGMT unmethylated, just having completed their XRT. And then also there will be another arm that will allow for patients to be treated who have progression. This will be a small phase 1 study. And then, of course, there will be biological markers, as I described, looking for the presence of this biological therapeutic in the blood. Because CAR T therapy is exploding generally in the world in terms of advanced trials for other cancers as well. And I'm not going to go much further because I want to be respectful of Dr. Dufault's time, but I want to just convey that message that I think gene and cell therapy offers us the idea or the possibility of bringing to life ideas that we feel the world needs in terms of these therapeutics, even if they don't exist today. And when the time is right and the preparation is done, we need to be willing to take that first step into the unknown. And I think that's what we're seeing in the gene and cell therapy community for brain tumors right now. And we look forward to engaging with colleagues across the world in these types of efforts, and certainly welcome further conversations with the entire PASNO group on this in the years to come. So I'll go ahead and pause there and thank Dr. Anam, Dr. Rosenblum for your leadership and bringing together this wonderful conference. And I look forward to all that you will do as part of our international community fighting brain tumors. Thank you.
Thank you, Dr. Carter. That was an amazing lecture, and I think it's worth looking at it again and again. And this will be a wonderful resource for all our students and trainees to have this summary and a state-of-the-art treatments with the current status. Thank you very much for an amazing lecture. So next we have Professor Hugues Dufault. He is a professor and chairman of neurosurgery department in the Montpellier University Medical Center, France, and the head of the French National Institute of Health and Medical Research. It's INSERM 1191 team, working on the plasticity of the central nervous system, human stem cells, and glial tumors at the Institute of Functional Genomics, which is the University of Montpellier and in Paris. He is an expert at awake cognitive surgery for slow-growing brain tumors, for his innovative work in neurosurgery and neurosciences. He was awarded Dr. Honoris Causa several times. He is the youngest recipient of the prestigious Herbert Olivicona Award from the Karolinska Institute in Stockholm. His research interests include brain connectomics, neuroplasticity, and cognitive neurosurgery. He has authored 4 textbooks, and those are amazing textbooks, actually, if you have a chance to read them, and over 400 publications in international journals ranging from neurosurgery to fundamental neurosciences, for a total of more than 23,000 citations. He is also a truly international neuro-oncology surgeon. He's always surrounded by fellows, trainees, and colleagues from Japan to Chile. He's a shining example of starting alone and building a team and creating an impact that goes beyond geographic boundaries. When he started at Montpellier, there was no one knew Montpellier. And then now with his research and with his work on awake surgery from there, everybody knows, or at least the neuro-oncologists know that city more than Paris at this point. So Professor Dufault will give a talk on perspective of awake neurosurgery with cognitive and emotional assessment of patients with low-grade gliomas. Thank you.
Dear colleagues, thank you very much for giving me the opportunity to share my experience regarding language and cognitive mapping, and monitoring in low-grade glioma surgery, about over 1,000 awake procedures.
With 25 years of experience based on early maximal connectome-based surgery, we changed radically the natural history of the disease by increasing the overall survival over 17 years and by preserving the quality of life of diffuse low-grade glioma patients, namely less than 1% of severe permanent deficit.
When I started 2 decades ago, the survival in this kind of low-grade glioma was around 6 to 7 years. In the French low-grade glioma consortium, we published a paper already 7 years ago, a prospective study demonstrating that we reached survival around 15 years thanks to early and maximal resection.
More recently, with my colleague Luc Taillandier in Nancy, we published survival over 16 years, but also with preservation of quality of life, namely a Karnofsky status at least 80 over 12 years. In a recent paper, we also demonstrated that when we do an extensive neuropsychological examination before any treatment in patients with low-grade glioma diagnosis, in over 55% of them, they already experienced language, episodic memory, attention, executive functions, personality, and so on, deficit. So demonstrated that the patients are not so well. These deficits are related to the invasion of the white matter tract connectivity. For example, invasion of the superior longitudinal fasciculus related to executive dysfunction, or an invasion of the arcuate fasciculus in the so-called right non-dominant hemisphere and mentalizing deficits, and so on. This is the reason why we propose to do surgery up to functional boundaries, considering both cortical and subcortical critical networks, namely to adapt the resection according to the individual functional anatomy.
This is possible only if we accept definitely that localization does not exist in the brain. We have to move toward a connectomic account of brain processing and to become neuroscientists in order to better understand mechanisms of neuroplasticity.
Even if functional imaging can be helpful, we have nonetheless to understand that there is no reliability at the individual level, because fMRI is not able to make the difference between critical versus compensable structures, and that DTI tractography is not the function, but just a reflect of the anatomy. This is the reason why we decided since 25 years ago to do a systematic awake surgery in order to benefit from cortical and subcortical mapping using intraoperative electrical stimulation and by doing online anatomo-functional correlation.
So how I do it means that before any surgery, I will save time to better understand what are the needs of each patient according to his or her job, hobby, habits, leisures, lifestyle, and so on. Therefore, into the operating theater, I will do a mapping à la carte according to the wishes of the patient, but also according to the connectivity in order to preserve the projection fibers and the association fibers, which are definitely the limitation of neuroplastic mechanisms. In other words, into the operating theater, my philosophy is to remove as much as I can a part of the brain invaded by a chronic tumoral disease according to functional cortical and subcortical boundaries identified in real time thanks to cognitive monitoring. So I will not use technology, no neural navigation, no DTI, no fMRI, no intraoperative MRI, no microscope, no ECOG, and you will see that you can nonetheless achieve 99% of good results. I do not understand why the vast majority of neurosurgeons now the habit to do awake surgery in the so-called left dominant hemisphere for language mapping and to continue to achieve resection under general anesthesia in the so-called right non-dominant hemisphere. Indeed, this right hemisphere is critical for so many functions in order to continue to enjoy perfect normal life, especially complex movement, spatial cognition, critical for driving, social cognition, critical for relationships between human beings, non-verbal entities, executive functions, but also emotion, personality.
Indeed, we recently reported by achieving post-operative cognitive assessment that at least 20% of patients still experience a deficit regarding cognitive function, especially regarding executive functions such as working memory or mental flexibility.
Indeed, it's definitely possible to incorporate further tasks like dual tasks or to ask the patient to name the item which was presented previously in order to monitor this higher order cognitive function. To give a little bit more detail, we published atlases, not only regarding the cortex, but also the white matter tracts of networks involved in the control of complex movement, especially regarding the bimanual coordination, which is definitely very important if you would like to play sport or to play piano or to be a surgeon. In the right non-dominant hemisphere, we demonstrated that it could be very helpful to incorporate the line bisection task, especially at the white matter tract mapping level, in order to identify the part 2 of the superior longitudinal fasciculus and to avoid any permanent hemi-neglect.
More recently, we published in Nature Communications an extension of the previous study by giving new insights into the frontoparietal medial network involved in visuospatial attention, which should be preserved during surgery.
We demonstrated that Broca's area does not exist, and if there is an output for speech, it is located within the ventral premotor cortex. So we have to better consider networks underpinning different subfunctions, especially for language.
The connectome-based surgical resection principle relies on the fact that whatever the lobar location of the tumor, for instance, in the so-called Broca's area or a left parietal area or a left temporal region, in all cases, we will be into the contact of the connectivity at the end of the resection, namely in this example, into the contact of the dorsal arcuate fasciculus underpinning the phonological pathway.
Of note, we have recently demonstrated that the anatomy of the arcuate fasciculus was not yet perfectly understood, especially because the vast majority of temporal cortical termination are not at the level of the so-called Wernicke's area, but at the level of the middle and inferior temporal gyrus. There is also a very important ventral semantic pathway underpinned by the inferior fronto-occipital fasciculus, and when we stimulate it into the operating theater, we will induce semantic prophagia. We also demonstrated that it was absolutely critical to preserve the left inferior longitudinal fasciculus, more basally located, otherwise we could induce difficulties regarding the lexical access. In practice, when there is an increase of the reaction time for naming, then the patient can have difficulties to return to work. It's very important to know that the right inferior fronto-occipital fasciculus is critical for this non-verbal semantic processing.
Even more recently, we already demonstrated by doing a very extensive evaluation of the behavior following surgery that a subset of patients still experienced some degrees of personality and behavioral modification following resection, especially regarding irritability, hypoactivity, disinterest, so with some possible negative impact on the quality of life.
It's also possible to ask patients to recognize emotion expressed by faces into the operating theater in order to monitor the so-called mentalizing, namely the theory of mind, which is absolutely critical for empathy and then for relationships between human beings.
The most important part, namely the results about 870 diffuse low-grade glioma are priority done in so-called eloquent areas, such as the frontal area, the Wernicke's area, the Rolandic system, the corpus callosum, and so on. We recently published this series in Neuro-Oncology, demonstrating that the mortality was zero, with less than 0.5% of severe permanent deficit. In addition, 85% of patients preserved their cognition, but also with 10% of them who improved their cognition following a postoperative cognitive rehabilitation. Very importantly, 94% of them returned to work with an impact on epilepsy in 80% of patients.
Regarding my own series, median survival is above 17 years. This is very important in order to increase the extent of resection by doing another resection a few years later, thanks to mechanisms of neuroplasticity which occurred in the meantime. For instance, in this example, I left voluntarily during the first resection the so-called knob of the hand, which was finally compensated 5 years later, allowing to remove this area in a patient enjoying a perfect normal life 3 months following surgery.
Of note, beyond the need to preserve the intra-hemispheric connectivity, we started to understand the role of the inter-hemispheric connectivity, typically when we induce a transitory supplementary motor area syndrome. We know now that the patient will recover thanks to a re-increase of the connectivity between hemispheres. Recently, we published a paper demonstrating that it was possible not only to use plasticity between a first and a second surgery, but also between a second and a third surgery, allowing to increase the extent of resection in diffuse low-grade glioma patients while preserving the quality of life. This allowed to reach a median survival almost 18 years. We also demonstrated that because this is a diffuse glioma, if it could be possible to do a supratotalization, namely beyond the flare abnormality visible on the preoperative MRI, then we can change radically the natural story of the disease with 16 years of follow-up by preventing malignant transformation and then death. In order to increase the rate of supratotalization, we proposed to arrive earlier by doing surgery in incidental diffuse low-grade glioma. And we recently reported a multi-center experience with Udine, Calgary, and UCSF showing 93% of survival after 10 years.
We also published in incidental low-grade glioma that 97% of patients return to an active life, including working full-time. To help younger people, we published Atlas of neuroplasticity in the MNI template, so giving them the opportunity to predict before surgery if the patient will recover or not according to the extent of resection, especially within the white matter tracts.
Knowing the limitation of neuroplasticity, especially the white matter tract, is very important not only for neurosurgeons, but also for medical neuro-oncologists and especially radiotherapists in order to preserve the quality of life and to adapt the treatment according to the better understanding of the connectivity at the individual level. This is the reason why we reported in neuro-oncology modification of the paradigm of management of low-grade glioma patients by trying to push the resection earlier, to reoperate the patient, and finally to postpone adjuvant treatment, especially radiotherapy, to preserve not only the quality of life, but also to increase the median survival. Indeed, remember that this multi-center study between Nancy and Montpellier demonstrated that the patient can live now over 16 years by preserving perfect quality of life.
To achieve this kind of results, it's very important to be a neuroscientist, because we are neurosurgeons, and then to be able to propose new models of cognition in order to use them for the preoperative planning, but also into the operating theater. Once again, to help younger neurosurgeons, we recently published a sole atlas in the world literature about 16 functional domains regarding the critical networks with cortical hubs and white matter tracts, absolutely essential if we would like to preserve the quality of life of the patients.
Now, the next step is to better understand the interaction not only within, but also across networks, and especially between both hemispheres. In this state of mind, we developed the concept of meta-network brain, namely demonstrating that the brain is a perpetual succession of new equilibrium states and is not fixed, which is very important for the management of patients with glioma.
Into the operating theater, this concept is very helpful because you can ask a patient to do two tasks simultaneously, to stimulate and to see that by disrupting some specific network, the patient is still able to move, is still able to talk, but is not able to continue to perform both tasks simultaneously. So the goal is really to do mapping and cognitive monitoring à la carte based on better understanding of the functional connectome at the individual level. And to this end, be careful to technology, because the risk for younger people is really addiction. And never this kind of information could be provided by the actual technology. So to conclude, beyond survival, even if, of course, we increased, as you have seen, the survival over 17 to 18 years, we have to preserve the quality of life of low-grade glioma patients, not only by avoiding to induce permanent hemiplegia and or aphasia, but also by preserving the higher order cognitive functions, such as the executive function, as well as the emotional processing, in order to allow the patient to return to normal life by preserving his behavior, his or personality, and then to be active for at least 15 to 20 years. So the goal is not just to remove a tumor with an oncological point of view, but first of all, to treat a patient as a human being by understanding the interactions between his or connectome and the natural history of the disease, which will be radically changed thanks to our management. Thank you very much for your attention.